let's say you get called to, or I'm bringing an 8-year-old boy playing with a loose dental crown, and now he has mild nausea, no bleeding or pain, respiratory rate's 18, SpO2 is 100, heart rate's 95, blood pressure 102 and 65, and GCS 15. So you have this object in the gastrum antrum, this large radiopaque object. What do you think about this?
So to start with, this is very, very pretty unlikely to happen, to ingest like a dental crown implant. But if it's happened, it's considered a very large object, more than 2.5, which require endoscopy removal most of the time. But we could accept endoscopy removal within 24 hours before like obstruction could happen, before like worsening symptoms like abdominal pain and nausea and vomiting. So most of the cases who presented to emergency department with such presentation, we will call GI team to see the patient to assess for possible removal within the next 24 hours to rule out and to observe the sign of intestinal obstruction.
And so just for all listeners, if they're looking to, and if you have show notes, I don't know if you put them, but there's a whole guideline on foreign body ingestions put out by the National Association of Gastroenterology, Hepatology, and Nutrition, or NASPSCAN for short, on basically on what it is, size, whether or not it's likely to come out, yes or no. There's no hard and fast rules. These are very rough guidelines, because when you say an 8-year-old, my son's 6, when he's 8, he's going to be smaller than my nephew, who's massive, and 8-year-olds, and so your development to the size of your gastric antrum and stuff will change. So sometimes, we'll opt to observe these kids. If it's an inert foreign body like a dental crown or a coin or a kid swallow Lego or things like that, then most of the time we prefer to let it come out naturally. Sometimes people do serial X-rays. Sometimes people will, skim through their kid's poop to see if they can find it. But certainly, if we know there's an almost no chance of it passing, if it's a little kid with a massive object, like we've kind of alluded to in this case, then yeah, well, it'll be planned for a relatively expeditious upper GI scope. If there's kind of very low probability of it being removed.
I think that's a really good point too, because that's the problem of pediatrics. You have these rough estimates of their weights, their vital signs, and we get called to a 6-year-old. I'm already doing the equation in my head for their weight and vital signs, and then you walk in and they're completely different size to what they should be. And now you got to pivot.
Yeah.
What's your recommendations for that? Like, how do you prepare for that or adjust on the spot without getting apprehensive?
That's a very good question. To be honest, if we have a patient who ingested like a known foreign body, and we saw the patient and he's completely asymptomatic, and we are suspecting this patient like he needs further imaging and observation, most of the time we call the expertise teams, which is a GI, and we will discuss the case with them based on their expertise. If they based on the history, based on the X-ray finding, most likely it will pass spontaneously without any intervention. We will try to arrange follow-up for such patient. But if the patient develop any symptoms or he show any significant concerns during our assessment, we will call them immediately for immediate intervention. So it's depend on the patient and depend on how he presented to the emergency department.
And I think building on kind of your question about how do you pivot in real time on a patient that you're not expecting, I'll say that for us is almost the norm, because we take care of a lot of what are called complex care patients, or kids who are premature or have genetic syndromes. So they might be 10 years old, but they might only be 15 kilos. So it is a lot about being adaptable and recognizing in real time. And a lot of this, unfortunately, fortunately or unfortunately, it comes with experience. So I've become pretty adept at guesstimating patient weights based on visualization. But at the end of the day, you also want to use your tools. So you have your Broselow tape. I know that's in all of our pre-hospital trucks. So don't feel like you can't change on the fly with what you were going with if you're drawing up meds or things like that. We do that all the time. We have a resus sheet in the ED that's built on a default weight. But if we come in there and they're nowhere near that default weight, I say scrap it, we start again, we're going to change the weight by 20 kilos. You know, you don't want to, to your earlier point, you don't want to get stuck in a fixation bias or not be able to make changes that you see as you go. So just be aware that that is certainly a possibility, and kids will, you know, some kids will be very thin, some kids will be very big. And, you know, the one thing I will say is sometimes people forget that, you know, bigger kids will often reach adult dosing and adult max dosing. And if you use per kilo dosing without recognizing that there's a max, you're going to go way past what's kind of acceptable dosing for a lot of medications. And from the pre-hospital space, I think of like steroids for croup or things like that. If it's a, you know, a 80 kilo 10-year-old, and you're not going to do 0.6 per kilo on 80 kilos, that's going to be like 40 milligrams of dex, which is like double what we would typically give the max dose for an adult. So just something to think about. Like, you never turn off your critical thinking brain in pediatrics, because they'll throw you a curveball every time.
And use the resources that you have.
Exactly.
I always remember walking in and seeing the pediatricians use the Broselow tapes or reference charts, and like, if they're using that, why aren't we using that? And this is all base hospital dependent, but it is written in our medical directives. You can use like Broselow tapes or other pediatric approved things. And just the cognitive offload, just here's the tape, measure it out. There's all the corresponding dosages. Even if they may be different from our medical directives, it's still so valuable to use.
This podcast is for educational and informational purposes only. It is not medical advice, does not establish a standard of care, and must not be used to diagnose, treat, or manage any medical condition or emergency. The content discussed reflects general principles that may not apply to every situation, system, or patient. Clinical practice varies by region, service, and jurisdiction. Always follow your local medical directives, clinical guidelines, protocols, and the instruction of your medical oversight or base hospital physician.